you lose a loved one, you can have, you have to move, you have financial difficulties, you may be in a car accident. So any kind of stressful event can put you at higher risk for depression. Insomnia is a huge one because, a lot of times people think as you get older, that people experience insomnia, but really the only thing normal about as you get older is that you may need less time sleep, but you shouldn't be laying there for an hour, 2 hours, not being able to fall asleep or have vivid dreams, because that can also be a risk factor for developing depression. Some of the protective effects, that as you get older, I think psychologically you can be more resilient because you've been through more experiences, and it has a protective effect. There was actually an article this morning in New York Times about what makes some people resilient, especially in this day and time in pandemic. And a lot of it had to do with your experiences and how you've handled the past experiences, or how you were taught of coping skills are huge. Higher education has a protective effect, higher socioeconomic status, engagement in activities with family, religious or spiritual involvement, volunteerism. All those things can be protective factors. And from all of this, as you can tell, like right now with COVID and with social isolation, unfortunately, we're seeing more and more depression in older adults. And I've seen an increased uptick in suicide attempts with older adults. And we'll talk about that in a minute. But as you can see, like with the protective factors, when the family's taken out, you can't go to church, you can't volunteer anymore, you can't go to your coffee, you can't go to a day program. All these things are stripping your protective factors from you. And depressive symptoms in late life, even though, I talked about how it can be different, but you can still, in older adults, what I find, especially in male older adults, what I find is that we see a lot more irritability. So people are more agitated and irritable, not so much depression, boohoo, crying, as younger people do. It's more of irritability, anxiety, what we call anhedonia, which means like you don't enjoy things like you used to. Sleep and appetite changes. It can be too much sleep, too little sleep. It can be you eating too much or you're not eating enough. Agitation, resistance to care. I mean, that's huge, like especially in assisted living or memory care, when people are just want to be left alone. Don't touch me, I'm okay. I just took a shower yesterday, which is probably not true, but that's what they say and think. Loss of energy, loss of interest, loss of libido, guilty feelings, hopeless, helpless feelings. And then the big one is excessive somatic complaints. And this is when people get $1 million workup because nobody can figure out why Mrs. Smith has so much nausea and vomiting, or why is she complaining of headaches all the time, or why is she complaining of pain. So you get $1 million workup to figure out, a medical problem per se. But to me, depression is also a medical problem because our brain is like one of the most important organs. So if it's not working, it's a medical issue. Which brings me to the point of pseudodementia. And as the name tells you, pseudodementia means it's not a real dementia, it's like a fake dementia. And it is because when you have depression, it affects your cognition, which in turn causes you to have memory loss, or objective of being having memory loss. And we'll talk about that in a minute too. But another differences with late life depression is that people can start talking about their deceased family members, their husband, wife, repetitive verbalization of like wanting to be with them, or talking about personal loss of like, oh, I had to move into assisted living, or I had to stop driving, and they can't stop thinking, talking about those losses. They start having social withdrawals because they don't have enough energy, they don't have any interest, so they just stop doing what they were doing before. And of course now, because of COVID, this is a huge one because we have cut everybody's ties from everything that they knew. So there's more and more risk of depression. And as you do get depressed, and we talked about anhedonia, which means like you don't want to do anything, people start taking their medications, or they stop going to the doctor, so they're non-compliant with what's ordered for them. They have poor hygiene, and they don't do well in rehab. I get a lot of consults from rehab facilities or skilled nursing facilities that so-and-so is not progressing, and it's usually because they're depressed. So usually they tell the therapist to go away or just go to hell. I don't want to deal with you because they're depressed. And another big one is failure to thrive, which is, you know, in kids, we also have failure to thrive, but this is an adult failure to thrive, which means you start losing weight and they stay in bed, and they're just not doing well. And as you stay in bed, you start losing muscle mass, so you atrophy. So you start not being able to walk. They can be wheelchair bound. So as you can see, the depression, as it starts, it's easier to treat at the beginning. The longer you wait, the harder it gets. Suicidal thoughts or wishes of death. I have so many people that, you know, they just kind of say, I just want to die. I'm just ready to die. Not necessarily suicidal. They're not gonna, and, you know, a lot of people have religious beliefs that, you know, if you kill yourself, you don't end up in heaven, or it's against their religious beliefs. So even if they're not suicidal, they're still wishing to be dead. I've had multiple people tell me that, oh, I just wish I wouldn't wake up, or I wish I was dead. And then when you press them a little more, they're like, no, I'm not going to kill myself. I'm not suicidal, but I just had it. I don't want to be alive anymore. And sometimes I've had people that they start refusing to eat or take their medications. And then when you press them, it's kind of like, you know, that they're trying to kill themselves that way, which I always say that's like the worst way to do it, because it takes a long time for you not to eat, and it's a miserable way to try to hurt yourself. So remember the pseudodementia that we were talking about, that it's kind of like a false dementia. This one is actually one of the ones that can be a reversible dementia syndrome, because it is secondary to depression. So 20 to 60% of people with depression, untreated depression, can develop pseudodementia. The good news is that if you treat it, a lot of times you can recover the cognitive dysfunction and go back to baseline. But studies have shown that if you didn't have any depression growing up or as a younger adult, and you develop late life depression, you're at higher risk of developing irreversible dementia like Alzheimer's. And these people at the beginning, they have more difficulty with executive function. And executive function has to do with decision making, judgment, and things like that. But the good news is, like I said, this can be treated if you try depression. This is huge, and it's becoming more and more of an issue right now, especially with COVID and people having lost their connections. I've seen a lot more suicide in elderly, and the highest suicide risk and highest completed suicide are actually male, white male, older than 65, single. So actually being married has a little protective effect with the suicide, or having a partner, it's has a little protective effect. Recent psychosocial loss, like if they've lost a spouse or a partner, or they've lost finances, social isolation, such as COVID restrictions. Chronic pain is huge, visual impairment, neurological illnesses, malignancy, all of these things that people kind of feel lost and they feel that there's no way of getting out of it, puts them at higher risk for suicide. And the reason that this is the highest completed suicide is that older patients, especially male older patients, own guns, and usually that's number one type of suicide is gunshot wound, self-inflicted gunshot wound. And I had one patient, unfortunately, that I've lost through suicide. And what happened was I had known them forever through the wife. The wife was my patient. And she was getting very demented. She was put in a facility. He came to me a few years later, and she was still alive. He came to me a few years later and was complaining of depression and dementia symptoms. So I did a couple of testing, I saw him a couple of times, and then the third visit, I shared with him that he probably has dementia too, but it's early stages, we're gonna work together, you're gonna be fine. But the next thing I know, the daughter called me a few days later and said that he had killed himself, left a note saying that they just couldn't afford having both of them in a nice memory care. And he said, I'd rather have her stay, and I don't need to be around for this. So, which was pretty terrible, especially I felt really bad because, and then after that, this was a few years ago, and then after that, I'm always, if I'm going to share somebody with someone that you have dementia, I try to have them come in with their family members to at least have that support. And so the next subject is depression and stroke, because 1 in 3 people experience depression 5 years after their stroke. And 20 to 50% of them is almost immediately after having a stroke. And sometimes people say, oh, well, I mean, wouldn't you be depressed because you just had a stroke? But no, not necessarily. Everybody who has a stroke doesn't get depressed because they're hopeless or helpless. It is something chemical. It's a neurochemical imbalance. You actually have decreased serotonin, which causes the depression. And it's a real thing, and it needs to be treated. Because remember I said when people are depressed in rehab, they don't do well. So it's really important for you to do rehab right after the stroke. The first 3 months is very important to do rehab. So if you're depressed, you're not complying with your therapy, you're going to have worse outcome. And depression is also very common after cardiovascular disease, such as heart attack or atrial fibrillation or embolism. So that's also very important. And again, I can't emphasize this enough. Depression is related to worse prognosis after a stroke or a heart attack. Again, it's because you are refusing to do rehab. Depression itself is actually a risk factor for heart disease. And I put this up here because I know it's a lot of words on here, but I'm just going to go through it a little slowly and just kind of talk about this busy slide. The reason I put this up here is because, as you can see, there's a lot of, at the bottom, it talks about anxiety disorder. To the right, depressive disorder. To the left, dementia. And the reason I put this up here is that they kind of all overlap, the three of them. So it's pretty important to figure out what the person is experiencing, because we have treatments, but sometimes the treatments can be different. But a lot of people that have depression also have anxiety. A lot of people that have anxiety also have depression. A lot of people that have dementia have depression and anxiety. So as you can see, it kind of overlaps. And one important thing is this impaired concentration can happen between the depression and the dementia. And that's what I was talking about, the pseudodementia. Because if you have, so in order for us to remember certain things, like let's say short-term memory, I have to be able to concentrate enough to put it in a certain part of the brain to be in order to be able to go back and pull out that information. So if my concentration is impaired because I'm depressed, it's going to look like I have dementia. And then the sleep disturbance is huge, right? So if you're not sleeping, your cognition is going to get worse, your depression is going to get worse, and of course, your anxiety. I know it's a lot on here, but I kind of feel like it's important to understand that why it's important to know what you're suffering from. And this is just another slide to emphasize the importance of how depression and anxiety overlap. So about 60% of people have depression and anxiety together. So, and the lifetime prevalence of panic disorder is like 30%. Lifetime prevalence of depression is 60% with social anxiety disorder. So it's pretty high, pretty high numbers, but they overlap. The good news is that the treatment is good for both of them, for depression and anxiety. Before I get into medication treatment, I think it's really important to know that psychotherapy actually works, and Medicare covers psychotherapy. So if you're one of those people that kind of says, I don't want to try medication first, and that's fine, but you do need treatment, you can think about psychotherapy. And there's different ways of psychotherapy. There's behavior therapy, there's cognitive behavior therapy, there's problem-solving therapy, brief psychodynamic therapy, and the reminiscent therapy, which is like you kind of review your life over time. And they're all effective treatments, but unfortunately, we don't use them enough because, a lot of us kind of feel like it's easier to just take a medication and fix it rather than me working on trying to figure out where the depression is coming from. And in multiple studies has shown that the combination of psychotherapy and medication, the two together, are the most effective treatment for depression and anxiety. Some of the preventive interventions, I think it's really important to talk to the patients that have chronic illnesses like diabetes, chronic pain, cancer, to talk to them about the depression and how this is affecting their mood. And behavior activation, which is also preventive, so like exercising, getting involved in a support group, which of course is really hard right now because of COVID, but you know there are they are doing support groups online, just like what we're doing right now. Problem solving skill training, and of course the volunteerism. These are all preventive interventions. And again, what they have in common is that you're with other people, which is nice. But we do have medications that they're all, actually, I like this one, because all of these medications, all the antidepressants work. It's which side effect would you like to have kind of thing. So I like this one because, you know, as you can see, you have different ways or exits of getting out of the depression. And we do have a lot of antidepressants, and most of these medications, well, actually all of them now are generic. So they're not expensive, they're very affordable. And as, like I said, they all work. I say jokingly, but I'm serious, like you would be like, okay, what side effect do you want? Because Zoloft can cause diarrhea. So if you're constipated, maybe you want to go with Zoloft. But if you're more on the loose end of stool, you may want to go with Paxil. And if somebody has heart problems, Zoloft is a cleaner, as we call it, a cleaner medication for cardiac problems. And citalopram and Lexapro are kind of in the same, they're cousins, because citalopram came first and then Lexapro right after that. Wellbutrin is more activating. So if somebody tells me that they're having difficulty waking up in the morning, it's more difficult for them to get going, Wellbutrin would be a choice because it's more activating. But if somebody has anxiety, that's probably not a good idea to have them on Wellbutrin. Remeron, as a side effect, it increases appetite and it also helps you sleep. So we use those side effects as a way of helping people that are not sleeping or not eating. I use a lot of Remeron for older patients because most of them, they're either not sleeping or not eating well. Effexor and Cymbalta are in their own little group. They're what we call SNRIs, which is serotonin norepinephrine reuptake inhibitor. And both of those are good for anxiety and depression. And also Cymbalta is used for neuropathic pain. So if somebody has diabetic neuropathy and they have a lot of chronic pain, you may want to consider Cymbalta instead. And, you know, sometimes if none of these work, sometimes we use Ritalin to help people with kind of that part of the brain, that the frontal lobe that kind of wakes up with Ritalin. We don't use a lot of tricyclic antidepressants anymore. Those are the older versions of amitriptyline, nortriptyline, because they have a lot more side effects with our older patients, with constipation, confusion. So you try to stay away from those type of medications. In 10 to 20% of cases are what we call treatment-resistant depression, and this is, so what that means is they're not responding to one antidepressant. So the first thing you do with this type of, when you're calling it treatment-resistant depression, you can augment the SSRI with like Remeron or Wellbutrin. You can switch from one class to the other, like SSRIs, which is like Paxil, Zoloft, Lexapro. You can switch it to SNRI, which is like Cymbalta or Effexor. You can also augment with antipsychotics, but they have black box warning, so we have to be careful in elderly. And the atypical antipsychotics, you know, they do a lot of ads for Abilify on the TV, and they're making it sound like it's an antidepressant, but it's really not. It's an antipsychotic that we use in conjunction with antidepressant to help with the treatment-resistant depression. Augmenting antidepressants with lithium or Lamictal, but we just have to be careful within the elderly because of lithium affects kidneys, Lamictal affects your liver. So you have to be careful. ECT is still the golden treatment for depression. However, every time you have ECT, you have to be under anesthesia, so it does put you at higher risk of cognitive problems. But TMS, which is transcranial magnetic stimulation, it's kind of started off with the ECT that, you know, they're like, oh, if we do a magnetic field to the frontal lobes, but you don't have to be under anesthesia, this may work. And it actually has taken off. And the only thing is a lot of insurances don't cover them still. And it is $20,000 to $20,000 for the whole treatment, because it's 6 to 8 weeks of treatments. It's 20 minutes of high magnetic field that they put on your temples, and you sit there for 20 to 30 minutes, and it's 5 days a week for 6 to 8 weeks. So it's supposed to work, and you can get it covered under insurance, especially if you prove that you have tried and failed several medications, and it's supposed to work. So this is my motto, I think it's everybody, like geriatric or pediatric actually, motto is you start low on the medication, you go up slow, but please don't stop low, because I've had this happen before, that they'll come to me and they're like, oh, I've been on this medication for like 6 months and nothing is happening, but they're like on 5 milligrams of Lexapro, which is not a lot of Lexapro. So you allow like 2 to 4 weeks after each titration, so before you switch, but please, you know, don't stop, because you come in and you're going to say, oh, I've been on everything. And then when you look at it, you may have been on everything, but you were on everything on pretty tiny doses, which doesn't count. It's not a good trial. So educating patient and family about the transient possible side effects is really important, because again, I always say everything has a side effect. So even if you took a little aspirin, if you look on the bottle, it has one of those accordion type tags that you take off, and there's a whole bunch of side effects. So everything has side effects. You just have to know what you're looking for. And again, they work. It's just what you pick. And this one I think is kind of cool, because as you see, at first you're going to have some adverse events, but it tapers off because your body will get used to it. But also the yellow line is therapeutic effect. So at first, when you're having the side effects, you're still not feeling better, right? And now you're feeling worse because you're like, ugh, I'm nauseated and I don't feel good. So don't give up, because the nausea is going to go away and the therapeutic effect is going to kick in. And again, it's important to talk to people about side effects, and you ask your doctor what the side effects are. The main ones for the antidepressants can be nausea, headache, anxiety, and drowsiness. And the nausea, a lot of times it can be dealt with if you take it with food, if you do some ginger drops or ginger tea helps. And again, it will subside because your body will get used to it. So don't stop too soon, because if you stop too soon, you're not going to see an effect, and it will go away. I mean, sometimes it doesn't, and you have to switch medications, but a lot of times it will subside. Some of the long-term side effects are sexual dysfunction and weight gain, which are, neither one are fun, but you can do drug holidays. And with the weight gain, you think about increasing your activity, decreasing carbohydrate intake. And that's one thing with depression itself. People actually crave carbohydrates, which is interesting because serotonin, the precursor for serotonin is carbohydrates. But unfortunately, that's not how it works, that you eat a piece of bread and your serotonin goes up, or you eat chocolate and your serotonin goes up. It usually ends up becoming into fat. So you can gain weight even if you're depressed. This just emphasizes again, so please, at least 2 to 4 weeks before you notice any changes. And it can take up to 3 to 4 months for you to see a difference. And when, you know, as soon as people feel better, they're always, that's their question is, when can I stop it? And I always talk about the fact that, you know, when you are taking a blood pressure medication, your blood pressure is under normal control. You don't stop your blood pressure medicine because that's why it's under control. So you need to wait at least 6 to 9 months before you stop the medication for it to, so you don't have a relapse. And I think I have a, yeah, I do. This one I like too, because it kind of shows you that at first, when you have the response and you're starting to feel better with the medication or with the therapy, and your mood starts to go up, and that's when people decide that, I don't need this medicine again. So they stop it, and you have a relapse. So you go down again, you restart the medication, you're able to kind of recover. But usually what is told is to continue taking the medication 6 to 9 months before you stop it, because the more symptoms you have, or the more episodes you have, because that's why like the diagnosis, the official diagnosis, like when you go to your doctor and they have to bill insurance, it's called major depressive episode. And the reason that they call them episode is because they're episodic. They can happen. But if you don't treat it, or if you stop your medication too soon, you're going to have what we call cycle acceleration, which means that these episodes happen more often, and then they last longer, they're more severe, therefore they're harder to treat. And each new episode impacts the patient's quality of life, obviously. And again, I can tell people until I'm blue in the face, don't stop your medicine. But hey, I can't help it because people do. 50% of them do. I don't take it personal anymore, but You know, that, and this is not just for antidepressants. 50% of patients don't listen to their doctors. Shocker, I know. But it is reality, but the problem is that you will have a relapse again. And the reason people stop their medication, it's 43% is adverse events. So, and of course, nobody likes having a headache or nausea or anxiety, but that's about 50% of them are because of side effects. And I just put this one in because sometimes when you try antidepressants, if somebody has any history of bipolar disorder, it actually increased the risk of suicide. And I know that's kind of hard to swallow that, you know, hey, I'm taking this medicine because I'm depressed and suicidal, but you're telling me that it may increase suicidality. And that is just a risk. So that's why, you know, when you start a new medication, and I know this happens all the time, that they give you new medication, they're like, oh, we'll see you in 3 months. And you should be like, no, I want to come back in 3 to 4 weeks. Because you need to be checked to make sure that you don't have an increased suicidal thoughts. And I usually hope in the real world, or in the perfect world, it will be you start medication, but also refer you to a therapist, which then the therapist can kind of get to know you while you're depressed and get to see you improve, and also make sure that you have that support system to check for suicidal thoughts. And I think that's my last slide, because I wanted to leave some time for Q&A. And it is, so we have 15 minutes. And I see, were there questions?
Yeah, we've got a couple of questions. One of them is loss of libido or sexual dysfunction an issue with older patients?
Yes, it is. And I know I'm not trying to be funny, but I know people just think just because you get older, you don't have libido, but you do. And actually, there was like a study a few years ago looking at increased STDs in long-term care facilities. So people are still, you know, they have libido, they have sex, and that's one of the reasons that some people stop their medication, because they don't want to have that lack of libido. Well, one thing could be that what usually how you deal with that is what we do drug holidays, or what we call drug holidays, which I know it takes the spontaneity out of having sex, but you can say, hey, I'm going to have sex on Saturday, then you stop your medication, you skip a dose on Friday and Saturday, and you have sex, and then you take your medication. So because it is related to the drug dosing in your blood system. So drug holidays are one way of dealing with the sexual side effects. Wellbutrin is supposed to have less sexual side effects, and also adding Wellbutrin to SSRI sometimes has been helpful with decreasing sexual side effects.
Another question, is it relevant to the times of day that you're taking the medications to the effectiveness of the medications themselves?
For side effects in general?
No, the effectiveness, the overall effectiveness of the medication, the time of day that you take it.
Yeah, so yes, it does. And you know, if you read the prescription information, like for Lexapro, it would say it can cause insomnia versus somnolence. So some people might take it and feel like they're buzzed and they can't go to sleep. It causes insomnia, which in that case, you take it in the morning. But some people take it and they're like, oh my gosh, I can't keep my eyes open, and it causes somnolence. So you take it at night. Wellbutrin, usually, like I said, it's a activating medication, so you need to take it in the morning. And there was a point that generic Wellbutrin had come out, and because it wasn't what we call extended release, people were taking it twice a day, and when they were taking in the evening, it was affecting their sleep. So that's really important to remember, that with Wellbutrin, you shouldn't take it at night. But with something like Remeron, it causes you to have sedation. That's actually what a lot of times we use it for, is to help people sleep. So you take it at night.
Right. Hey, guys, if you have any questions, please feel free to send them through the chat option. That'd be the best way for us to get them going.
So there's a question about life review therapy. Yes, that's really awesome. And actually, there's some really good classes in Boulder. I had a couple of my patients that had taken this life review reminiscence therapy. And basically what it was that they were writing about their life history and processing it with a therapist. And I think it's an amazing way of healing and trying to understand yourself, trying to understand your relationships. Like I said, there's several classes online. There's, I know there used to be a class in person in Boulder. I'm sure they're probably online nowadays, but yeah, if you can do it and if you can afford it, because that one, they don't cover, insurance doesn't cover it. It's a really neat way of getting some therapy. So the next question is, do some of these medications react differently if someone has Alzheimer's versus Lewy body or frontotemporal lobe dementia? I can do a whole hour of lecture, which we may actually do, Adam, because
we may.
Yeah, that's a really good question, and it is true. So people with Lewy body dementia are very, which if you're not familiar with what Lewy body dementia is the type of dementia that you can have visual hallucinations, Parkinsonism, and memory loss. And they're a lot more sensitive to medication. So you have to be careful what you use with Lewy body dementia. You use smaller doses. Alzheimer's dementia, a lot of times people do get anxious and depressed. A little bit of SSRI can go a long way. You usually don't need huge doses for Alzheimer's patients. Frontotemporal lobe dementia, that's the one that you have difficulty with your frontal lobes. Usually if you've had multiple head injuries or alcohol history of severe heavy alcohol use, even if you quit 30 years ago, you're still going to have the effects 30 years later. And that one is a really hard one because we don't have a lot of medications that work for that type of dementia. And they're usually also very sensitive to medication and the side effects. And remember what I was talking about, the brain shrinking, kind of like all your organs are shrinking. As your brain shrinks, you have less receptors in the brain. So these medications work on the brain, work on the receptors, So you usually don't need really high doses of the medications.
Dr. Long, in older adults suffering from chronic pain, if they're utilizing antidepressants along with like opioid therapies to control that pain, do those medications kind of contraindicate each other at all?
No, they don't. So and with chronic pain, level of depression is pretty high. And they have done studies that if somebody's depressed, they actually have less pain threshold. So you feel the pain more when you're depressed, which is kind of ironic because you have the chronic pain, but you're also depressed. So you're feeling your pain more. And so it becomes this kind of huge comorbidity together. And with the antidepressants, the nice thing is, like I was saying, that with Cymbalta, that one actually works pretty well for pain, and they do work together. So and some people have been able to get off their opioids, as they get on the antidepressants.
Okay, there's another question that just came in. Any overall thoughts on the use of cannabis for depression in seniors? And I know this is a topic, just so everybody knows, this is a topic that we've actually been working on for a while. It hasn't gotten off the ground yet. And we're planning on doing a cannabis educational series sometime in the future. But Dr. Long, can you touch on that a little bit for us?
Yeah. So unfortunately, we just don't have enough. And I know everybody thinks like cannabis works for everything from, paper cut to PTSD. But we just don't have enough information about cannabis and depression, especially in seniors. From my experience of the patients that have taken it, a lot of times they ended up, and they may have taken too much of it, but of course the edibles are more stronger. They experienced hallucinations and paranoia. And it was really scary this is like 3 people I know that, over the years that they said it was horrible experience for them. And then, that one lady called to store back, and the guy had said, "Oh, you just took too much. You just take little or less or 1/8 of it." And she was like, "I'm not doing that. I'm not doing that anymore." It was horrible. But with dementia and cannabis, people get more confused. Sometimes I'm hoping there'll be some studies doing CBD oil that I've had families that swear that the CBD oil works for their agitated dementia patients, which would be awesome without like the THC, without the hallucinogenic part, and without the part that would affect their confusion. If we're able to decrease agitation and CBD oil doesn't have any side effects, that would be really great to see more studies coming out that way.
And that one truly does need to be like a full-on series about cannabis, just because of all of the different, receptors and the different, there's CBD,
Right.
THC, all the different kind of components to cannabis that it's like it's a whole other topic.
Right. And the problem is like we have like the studies that we have, they're not placebo studies, right? They're not, it's all very subjective of, oh yeah, I felt better. But we don't have a double-blind study of, here's an edible that has THC, here's an edible that has placebo, and then let's see who gets better. We just don't have any studies like that. So hopefully, as of course, it's all about the money. So I don't know if anybody will ever do it or not, but because what if it comes out that it doesn't work, you know, because they don't want to have negative effects either. So, but hopefully we'll have some with CBD oil. I think that would be very cool. So somebody's saying psilocybin with, yes, this is very interesting because the studies are coming out that it's helping with PTSD and depression. I do believe that this is going to be legal. Are you saying it's legal in Boulder, or just saying there's a study? Because there are several studies, and I do believe that this is going to become the next big thing. You know, like ketamine just came out. MAPS, I don't know what MAPS is, but ketamine spray just came out for depression, and it's working really great. And I think this is going to be the next legalization of. So I don't know what MAPS is. I'm sorry.
That looks like all of the questions that have come in so far. I mean, if you guys have any more questions, I mean, we'd be happy to answer them. We have a few more minutes. In any questions regarding AltaVita as well, I'm more than happy to answer those too. But definitely Dr. Long and I will be working together to come up with some more educational events. Dr. Long's fantastic about doing these. Typically, you know, pre-COVID, we were doing these in person here in the community, and we're going to be working forward during this time to continue to bring you guys some educational series via webinars. I know it's not the same for you guys, just as it's not the same for us because we don't have that interaction with you, but you know, we'll continue to work to bring you guys some great educational pieces. I don't know, maybe based off of some of the questions we got, we'll maybe be able to get some other dementia pieces together. So thank you guys for joining us.
And for everybody that's here, we do have our, I'm going to plug in our Alzheimer's walk, even though we're not walking, but we're talking. So if, I think, Adam, you should send a link for our Alzheimer's walk. And if anybody can make a donation or join our group, that would be awesome.
I'll definitely get that sent out.
Yeah, because, you know, what happens is since we're not doing the actual walk, I think they're having really hard time raising money, because like last year, the goal was, I think for Boulder, the goal was like 200,000, and they surpassed that. We were actually, I think, number 3 team in Boulder. But this year they're having trouble raising money because I think the excitement is not there, and you know, people are worried about other things in life. So if any of you can donate, any little thing helps.
Yeah, I'll definitely send out a link to that.
Okay. And then any comment on usage of amino acids to assist depression and anxiety? Yes, there's been a huge kind of talk about that too, and I think by itself it's probably not as effective, but in combination with, I mean, for major depression, in combination with antidepressants, there has been some really good studies that they are helpful. But again, you have to kind of be careful about where you're buying them, what source, because they're not regulated. So a good source of amino acids. And also another one is methylfolate, which is folic acid, the precursor for folic acid, because when you take a folic acid supplement, some of us can't metabolize that. but with methylfolate, it goes right to your brain and it helps with serotonin production. So those are a couple of supplements that you can do for sure. Thank you. And somebody said thank you for the entire AltaVita staff and beyond. And thank you again. Yes, we do have awesome staff, and it's an amazing place. I love it there. And you know, you can feel the energy when you enter the building, that it's different than other places. But
I think we have to credit that to you know, our medical director.
Thank you.
leading
Yeah,
us.
it is my baby. So, but I always joke, I'm like, it's a teenager now, but but we've grown for sure. But it's still that kind of the family-owned, smaller place. Well, thank you, and we're right on time. Look at that.
We are. Well, yeah, thank you guys for joining us, and keep an eye out for future educational talks. Thank you, Dr. Long, for joining us tonight and giving us some really good education on late life depression.
I just have to say, it's really weird not to interact with people.
It is.
So now I get it, like with all these comedians that are trying to do their shows every night. I'm like, I don't know how to do it because it's really hard. But I hope from their comments, it sounds like it worked out okay. So.
Yes.
All right. Thank you. Good night.
Thank you. Good night, Dr. Long.
All right. Bye.
Bye.